Hello, everyone. Good morning. Namaste. This is one of my favorite topics, blood-based biomarkers for Alzheimer's disease. I have no relevant financial relationships to disclose. I do intend to discuss off-label use of blood-based biomarkers. So currently, they are not FDA approved. I'll describe blood-based biomarkers closest to routine clinical implementation in diagnosis and management. So currently, we don't use it routinely, and we'll talk about when we might, and then discuss the limitations of blood-based biomarkers for Alzheimer's disease. So if you ask me, is there a single test standalone to diagnose Alzheimer's disease today? The answer is no. But all these things are so rapidly evolving that this answer may change in 3 months, 6 months, a year. Blood-based biomarker testing is one piece in the diagnostic process and should appear much later in the process. So that's the take-home point number 2, that it's just one piece and you'll have to go through much earlier process in the diagnosis before we actually do or order biomarker testing. And again, at this point, the interpretation is so complex that I would say only dementia specialists should be the ones ordering the biomarker testing and then interpreting them. If you wanted to just do one podcast to complement our talk today, then this would be the one. Jerry Powell, Dr. Nathaniel Chin, Dr. Nate Chin, is the director of Alzheimer's Disease Research Center at Wisconsin Alzheimer's Center in Madison. This is a fantastic podcast, and it talks about how blood-based biomarkers is already changing how we approach diagnosis of Alzheimer's disease. I have a transcript here. So this is from his transcript. A blood test looks just as good as the spinal fluid, and it looks almost as good as these PET scans, meaning amyloid PET scan. So that's important to know. This is the study amongst many that really altered clinical practice. So after this study in July, Mount Sinai opened up a whole new plan to diagnose Alzheimer's disease early using blood-based biomarkers early in the process. So in this study, by the way, this study was in Sweden, and they studied people who had mild cognitive impairment or Alzheimer's disease, dementia, or other dementias. They tested clinical diagnosis. So these individuals had clinical assessment, cognitive testing, and say routine neuroimaging. And then the primary care gave a diagnosis, the dementia specialist gave their diagnosis, and they had biomarkers results available. And then they compared, and they found that if you use biomarkers, then the accuracy goes up to almost 90%. So one of the things that I tell patients is that even though maybe I'm the only one who considers myself a dementia specialist, I could be wrong without having biomarker testing in my clinical diagnosis. So it's very important to keep that in mind. Again, now we have guidelines that tell us how to approach, and we need to try and follow these guidelines as much as possible. And blood-based biomarker testing is much below in the guidelines. The advanced diagnostic testing that you see almost in the end, that's where this would come. So I would have to obtain consent. Should I do this assessment for MCI and dementia, then do history, exam, and all these other things before we come to that step where should we do a blood-based biomarker testing to help with the diagnosis. So I had this case, the grandson, who's a physician, brought his grandfather, and I diagnosed the grandfather with moderate stage probable Alzheimer's disease dementia. And he said, can we confirm it? He's heard of biomarkers. So I said, yes. Can we do it by blood test? I said, yes, but it's not FDA approved. But you can get the blood test locally. You will have to pay out of pocket. And he said, let me think about it. I said, we can do CSF testing, but it'll be hard on your grandfather. And we can refer you to amyloid testing in other states. Again, it'll be very burdensome. He asked me if the test is negative, then what could be the cause of dementia? And I said, number one, there are many other causes, especially vascular dementia. Mixed dementia is actually the most common cause of dementia in individuals 80, 85 plus. There is something called late limbic predominant age-related TDP-43 encephalopathy. So it's a mouthful, but it's another neurodegenerative disorder that happens especially in individuals above the age of 80 and can cause hippocampal atrophy. It can look like Alzheimer's disease. It can quack like Alzheimer's disease, but it's not. It's a very different misfolded protein in the brain. And so, yes, I could be wrong, and your grandfather could have a different kind of dementia. Even though the clinical assessment shows rapid forgetting, the brain scan MRI shows hippocampal atrophy, everything points towards it. Also, his brother, so the patient's brother, had dementia that also looked similar. So we didn't have ApoE genetic testing, but if it's ApoE4, ApoE4, it's very likely that this is Alzheimer's disease dementia. Then he said, I'm worried about my father. He doesn't want to get tested, but he's showing a lot of forgetfulness. So what about doing that blood test for him? I said, well, it's down in that diagnostic process. So first, he'll have to come to, say, our St. Alphonsus Memory Center. We would do a thorough assessment, history, physical exam, mental status exam. We will do a paper and pencil cognitive testing. Even if the cognitive testing, like Montreal Cognitive Assessment, comes out abnormal, like mildly, and indicates this could be mild cognitive impairment, we could be wrong. Your father could be anxious. He could be depressed. There's so many other factors. We would have to refer him to a neuropsychologist, Dr. Black, for more detailed cognitive testing to get this diagnosis of MCI. And let's say that we do that. He has MCI diagnosis now. Then we could consider doing blood-based biomarkers. Could he qualify for this new disease-modifying treatment? Then I would say yes, but for that, you would have to have FDA-approved biomarkers, so either amyloid PET scan or CSF testing. Let me read now something that you guys will be surprised to hear. This is, again, Dr. Nate Chin from that podcast I mentioned. So this is his words. Let's say someone comes in and they have dementia. We've diagnosed them. We've done this proper workup. They have dementia, mild stage dementia, and we get a PET scan and it's amyloid elevated. Well, traditionally, we would say, okay, well, you have dementia and it's due to Alzheimer's disease. But if we knew that they had just become elevated in amyloid, say in the last 2 years, and 2 years ago, the brain scan was amyloid negative, then I would say to you, no, that's not Alzheimer's disease. And we'll come to that. But the key thing is to understand that the amyloid process has to go on for years. Then it triggers tau pathology. That starts for years. Then you have neurodegeneration. Then you have cognitive decline. And then you get diagnosis. So just having a test positive, even if it's amyloid, FDA approved amyloid testing is not enough. So if I do a blood-based biomarker in your father and it's positive, that still doesn't mean that the memory problems are because of Alzheimer's disease. So then he asked me, then can you do another blood test that will tell us? I would say in research setting, yes, there is something called MTBR tau 243. So M for microtubule, MT, binding region for B for ball, R for Rome, MTBR tau 243. It's in the research setting, and it might come out in the clinical setting. And that is a marker of the development of tau in the brain. And when tau develops in the brain, that correlates highly with neurodegeneration and memory loss. In fact, the spread of the tau can even help you know biological staging, which is different from clinical staging. So clinical staging is, say, MCI, mild dementia, moderate dementia, severe dementia. In biological staging, you can be MCI, but you can have much more tau, and then you would not have a good response to disease-modifying agents. So again, in the future, we will be doing biological staging to find out which individuals will be best to try and offer disease-modifying treatments. And then you can do a tau PET scan, but again, that's even more difficult to obtain, even in research settings. So then he says, what about me? What if I just go ahead and do it? I said, no, I don't know any expert who would even know how to interpret, because we haven't studied it in asymptomatic people. Currently, we are doing it. So if you want to take part in research, go ahead, but please don't. But you know how it is, like, 23andMe and genetic testing. I've had so many patients who went ahead and did ApoE testing, and at least the cases I know, they have had anxiety since the day they got the results. So this is not a small thing. So as I mentioned, the blood-based biomarkers are not currently FDA approved. CSF-based biomarkers are FDA approved. We have done it at our St. Alphonsus Memory Center, but many a times we get it as indeterminate. And you can get the same thing with blood-based biomarkers. You can send it to Mayo Clinic and it'll come back as indeterminate. It's almost like 15 to 20% of cases. So then you would have to do more biomarker testing. And as I mentioned, blood-based biomarkers like the phospho-tau 217 is as good as CSF and nearly as good as amyloid PET. So not exactly as good. What does that mean? It means that you can have blood-based biomarker tests negative and you can have amyloid positive. So the blood-based biomarkers was false negative. So again, it's important to realize that. And we need to sort this out. And that's why we need much more research to guide us. All this story of biomarkers started, honestly, just 9 years ago, and it's amazing how rapidly it has developed. So we have amyloid biomarkers, tau biomarkers, and neurodegeneration biomarkers. So when we do blood-based biomarkers, which is the future, as I said, people would not want CSF. Amyloid would be amyloid PET, tau PET would be too costly. Then you're looking at these biomarkers. So if I do neurofilament light chain, if it's elevated, then there is neurodegeneration, meaning loss of brain cells, brain connections. And if I do glial fibrillary acidic protein, if it's elevated, it shows neurodegeneration, but also inflammation, neuroinflammation. So again, in the future, we will do more biomarker tests, not just for Alzheimer's, but even for frontotemporal dementia, Parkinson's disease, and other neurodegenerative disorders. This is just another example of what I said. So Dr. Nate Chin at Wisconsin ADRC, Alzheimer's Disease Research Center, they have a WRAP study, WRAP, Wisconsin Registry for Alzheimer's Prevention. So they've done PET scans. Now, this is CSF test, and this was not done in Wisconsin, but they have the similar tests done with brain amyloid. And they have seen people, now they have 20 plus years of data, all right? So seen people who have been amyloid negative, then they developed amyloid positive. They had amyloid positive for like 15 years, and then tau started coming up. And then tau went on for 5 years, and then they started showing neurodegeneration, which means neurofilament light change or other biomarkers started going up. The brain scan started showing atrophy even before clinical evidence of cognitive impairment. And then you started having subjective cognitive impairment. Then you started having MCI. So it's again important to realize that it's a long drawn out process, and we can't just say that biomarkers means that I have it. Currently it's phospho-tau 217 that all the experts say is the blood-based biomarker tests to do, but this might change. It's so rapidly changing that we don't know exactly until the FDA approves it, say. So now we have guidelines, all right, that tell us what to do. So we should just follow these. So if somebody says, can I do it on my own? Because now you can do amyloid blood-based biomarker on your own. I would say no, based on these guidelines. Don't do it. Don't get a friend to order this tau testing, okay? If somebody needs to order, it has to be in the context of an assessment and preferably by a dementia expert. They should order it and then interpret it. Well, can I, dementia expert, order that in asymptomatic individuals or individuals with subjective cognitive impairment? No, I shouldn't, because we don't have studies to guide us how to interpret. If I have individuals with MCI or Alzheimer's disease dementia or other dementias, then many of them will benefit from blood-based biomarkers. So again, we need to do it case by case. Now, this applies to everything I've said applies to white population, because 95% of all these studies are done in white population. So if the same son who was white was, say, Hispanic, I have another case of Hispanic, 63-year-old, the daughter came and she asked me the question, and I said, everything I have to say doesn't apply to you because we don't have research to tell us whether all these numbers are true regarding accuracy, sensitivity, specificity. So please wait. And I would say even one step further, until we have a very comprehensive, up-to-date overview of blood-based biomarkers and appropriate use criteria, like the one I mentioned, but the one I mentioned is just by one group of experts, and they published it in an Alzheimer's Association journal. We need much broader group and consensus for us to truly be sure and do no harm. We need to talk as a team whether blood-based biomarkers may do more harm than good, because now they are just available for people to do it. I do believe that blood-based biomarkers will be the standard of care in the future for early, accurate, faster diagnosis, risk assessment, and then even monitoring treatment. We are not there yet. Let me stop here, stop sharing. Happy to take questions. Thank you.
Wonderful. Thank you, Abhilash. So we can use the chat to ask questions, make comments, or just unmute.
Everything is crystal clear, Lindsay.
Doubt that one.
Very good presentation. If someone takes the phospho-tau 217, is there anything that they can take to slow the progress or bring the results back down? Or
yeah, so great question. So let's say that I have MCI and Dr. Kuntz orders the test. I've done neuropsychological testing. Dr. Black says I have MCI, and phospho-tau is positive, so this would be probably MCI due to Alzheimer's disease. Currently, the only FDA-approved drug is a very expensive drug. In my personal opinion, very dangerous. I personally don't think the benefits are worth the risks unless I'm desperate. So let's say that the minute I get the testing and Dr. Coons gives me the diagnosis and I lose all hope, then maybe these disease-modifying treatments are better than me just losing hope for the rest of my life. But otherwise, there are high-risk medicine. There is a risk for me to have brain bleeds, and the benefits are very small. Other than that, there is no evidence-based medication that one could take to slow down the progression from MCI to mild dementia and further. But now we have other team experts, so please, let's get them involved. This is just an opinion, so we need more opinions.
Abhilash, we did have a question in the chat. You just touched on it a bit, but you may have some more to add about discussing the cost of the tests.
So yeah, the cost is around $200 to $250. LabCorp and Mayo Clinic labs do it. You guys can put in the chat, is that too much? Not bad. Surprise, it's whatever the number it is.
So my understanding, just to clarify, so that cost is for the blood-based p-tau 217.
Correct.
And there are other blood-based markers that people could get. The amyloid can be drawn in blood, and then that adds to the cost if it's on the blood.
Correct.
Okay.
Correct.
Great talk, by the way. I'm encouraged to see a lot of discussion about this and anxious to hear what other people think.
Thank you.
I think you're right that I think it was Lori asked a really interesting question about what can you do if you get that answer, because the treatment isn't really that much, the availability and who actually meets criteria. I think I saw an interesting article in the Annals of Internal Medicine last November. I'll put the reference in the chat, but they talked about using these biomarkers, the serum biomarker, as a bridge to determine if this person could be referred on for further anti-amyloid treatment. And then they would need either the CSF or the PET amyloid.
Yeah.
It was interesting use of it right now, especially in our more rural areas where we don't have access necessarily to the newer treatments here, but whether to send someone on or not, we could find that out.
Right. Yeah.
Abhilash, we have another question. So it sounds like the biomarker testing should require standard genetic counseling, even with positive results. It doesn't mean the disease will present. Is this correct? And can you discuss what research is focusing on now?
Yeah. So again, let's go back to the basics. So you can reach 100 years of age. You can have Alzheimer's disease in your brain. So you have amyloids and tau tangles. If you have both these proteins, you have Alzheimer's. But you did not develop MCI or Alzheimer's dementia, right? Then you can be 100 years of age and have no Alzheimer's proteins in the brain, all right? So we need to realize that not everybody is going to get Alzheimer's pathology as they age. But we don't know why some people manage to have the disease in the brain and don't get it. But the psychological effect of this A word, Alzheimer's, or the D word, dementia, and now even the M word, MCI, people are starting to read up and getting extremely stressed, is so high that yes, we need to do a lot of counseling, a lot of spending time. What does it mean? Because I've had patients who have, when they have seen the blood results, it's very different than if I give a clinical diagnosis. And even worse, if they see the amyloid light up in the brain, it's like a punch in the gut. you can't take these results back. Like you can't take the results of ApoE4 and figure out a way that your brain never remembers it, you know? So yes, a lot of counseling. And remember, now this will impact your family members. So you know, please keep all those factors in mind. And then you say, I won't tell the family members. Then you have all these other issues about not telling, you know?
How much does inflammation play into whether or not these amyloid and tau tangles present?
Correct. So there are a lot of experts who would say that's where all the money is, that it's all inflammation. The people who are not developing MCI and dementia, the neuroinflammation is very low. Currently, we have no reliable way to measure it. But if we had it, then I won't be surprised if that hypothesis is true, that it's all neuroinflammation, which is separate than our body inflammation. And whatever we do to reduce inflammation in general would be a good thing. And remember, Alzheimer's disease is just one. You can have neuroinflammation contributing to cerebrovascular disease and all kinds of other, even Parkinson's disease. So yes, I think it's a big thing.
I really appreciated you commenting on the do no harm. That just really touches my heart. I have two parents who have both. My dad died of Lewy body dementia and Alzheimer's, and my mom has aphasia and most likely frontal temporal dementia.
Oh my.
I really appreciate that because, you know, my kids are all, when they see their grandparents with dementia and then they worry about their parents. And then of course we always internalize that fear for our own selves. So I just wanted to know I appreciate that.
Yeah. Let me tell you now, anybody who says that they know the future, that it's all going to be a decline, that's not true. We have so many stories of people with the diagnosis that are living and thriving. It's not easy, all right? And I hope I can be that person. But brain neuroplasticity is where we can hang our hats.
Yeah, if I may, thanks, Dr. Desai, for that great talk and for everybody's questions. Just clinically speaking, how I think about this in my practice, I'm not typically recommending or even offering these blood-based biomarkers. If people come to me with questions, we're talking about it in terms of the things you heard here. But why I think this presentation is important is thinking about the future. And that's the excitement here, right? Is that we imagine a day when we do have medications with which we have great confidence that they can change the course of the disease. And therefore, there's great value in knowing at early stages in this disease. And therefore, there are interventions that are worthwhile pursuing. And so I think it's exciting that there are lots of medications in phase 3 clinical trials, and that it's exciting that we have blood-based biomarkers. You know, they're both being developed at the same time, right? The blood-based biomarkers are being developed and explored at the same time as the drugs, and one study supports the other and its value. But we're just still in early days around all this. So there's hope around all this for the future, but in terms of clinical relevance, not really changing approach as of yet for me. And that's kind of my perspective on that. If other, like Sue, wondering your thoughts.
Yeah, I agree. I think it would be a little frightening to just do these, right? These biomarkers. They're definitely recommended only when there has been a clinical assessment done, a very good, thorough clinical assessment. And like Dr. Desai said, this is late in the algorithm. I do see a use even now, though, for folks that really are charged up to do anti-amyloid treatment, and we think maybe they would meet all those criteria for the appropriate use requirements for lecanemab or donanemab. That's a whole nother 4-hour talk, right? But if so, you know, maybe doing that would help at least I've seen that used at other brain centers around the country as a bridge before we do the CSF biomarkers or send them for amyloid. But agreed, you're kind of going down an area where all those aftermath outcomes have to be discussed first, and that takes a lot of time with patients. But it's really exciting to see it coming